Let me ask you, do we have any idea about the residual urine, how much urine they were able to take from his bladder when the catheter was inserted?
I,
The reason I ask because it's unusual with D. infrared to have incontinence of urine. Usually when you have incontinence of urine in the face of these other symptoms, it indicates spinal cord pathology. And in that case, you will have residual urine will be significant. That's why I asked. I think you might have.
There's no history of trauma.
no history of trauma, just sudden pregnancy. Yes.
And it's very unusual to have back pain with Ray as well. To be honest with you, but it usually is an indication of a local situation that is inflaming or impacting upon the nerves. Something to consider.
Any history of cough,
No history of
weight loss.
no history
Because
of
we have to think about TB. It's fine in this environment.
And when I examined him earlier, he was getting some of the sensation in his right leg, none in his left, up to the level of umbilical, but he has no motor strength or reflexes after this whatsoever. I guess I was most interested if we had any idea about the residual urine and the x-ray, because initially the other physician, he wasn't aware of what the x-ray showed.
No, the X-ray was done after he had been tried.
Okay.
So it's on continuous rectal drainage.
Yes, sir.
Is the X-ray available?
For them,
Teaching hospital.
it has been on this strike. So that has tended to the things.
Has he been afebrile?
He's
Spike
afebrile.
temperature. He's afebrile. Okay.
Do it,
I did.
We don't have a history of previous infection in the last few weeks from him. That goes along with being away. I think that's why you asked me about cough and so forth.
Yes.
Yeah. They call him out of it. Yes, because there was no sensation up to here. But today, we're surprised. Yes. So we are encouraged the family so that when the levels function, the muscles will be there to very happy.
I think we should have a look at that.
Yes, I would like to, if they can provide it. Well, I'm sure they can.
Well, the children could be good because I'm going to be brilliant. So, being busy, that's Saturday, the sanitation. And yet, I'm not being
I think it can be found him. I like
Well, thank you for trying.
we hope he will recover.
No, I think it would be nice to see it. We can get it later on and show it to them.
Later.
Is this inspection? If he didn't improve with steroids, have to consider the possibility. Because you cannot explain the pain. Correct.
So, man, the first time. So, I can
That's what concerns me. That's why I wanted to come back, because it did not fit the typical picture of Gene Boré that I'm used to seeing, to be honest with you. Hopefully, it is Gene Boré.
So you visit the son.
Are you able to do a sedimentation right here?
So Monday night.
That sometimes helps.
in the morning. You go in the
You get that picture. It
No, I
was
can
gradual.
understand.
First from one leg, this leg first became paralyzed on a Sunday, then the next day it affected the other leg.
Did the sensation loss follow that same pattern?
Yes.
So first this leg
This
and
leg,
then this
then the
leg, the
next
other
leg.
one. See, that Guillain-Barré is almost always symmetrical.
Symmetrical, yes.
ma'am. Which further indicates the likelihood of some local compression.
Compression.
That would be my clinical assessment.
The X-ray, we should see it.
Okay.
Get the X-ray people to get out the feet. Even if we have to look at it later on. I think.
We would look at it whenever they can find it.
Yes.
Yeah.
But I would like to see it.
You know, sometimes has pain in this right back.
Because there was, when it came, there was no sensation.
The other thing you think about is any ischemia involving the anterior spinal artery, but he wouldn't have total loss of the lower extremity. So I really think that's not something. But even in that case, I have seen it. But yes, the X-ray will be helpful.
We will get the
So
X-ray.
Ms. Evans,
And I think we should have a test.
How about blood transfusion?
Not screen for a screen for virus or so before transfuse.
How about do all of the surgical patients get screened for AIDS?
Surgical.
Or how do you this? Do you
Is the
just,
blood before we do?
okay.
We screen the
Screen-
blood
oh,
for
yeah.
AIDS
Yeah.
and hepatitis before transfusing.
How about the patients? Do you have any protocol for screening patients?
We screen them at times when we notice the patient, we send the blood for screening for AIDS.
But now we screen everybody that comes to any patient.
Everybody, every inpatient gets AIDS and hepatitis.
Yes, okay.
That's good. Okay, yeah, they have laws that prevent us from doing that in America, but the doctors would like to do that, but they don't do it.
Just suggested he should make some notes.
what I have said here, this is information on background of what the company has done. Thank you very much.
So I'll be waiting for the I was just saying they and the high rate of blindness. In fact, we've just completed a prevalence study.
Yeah, medical college, teaching hospital. He has pain. He has pain. Oftentimes, comes in symptomatic
Is there any way that we could get a copy of this stuff?
Yeah, began in the left extremity.
Oh, okay. Both of the measures. Okay. Okay. So you
ability to let you know what you have at the end of it.
I said, well, let's go once we have more time in the clinic. So she's told him that I will refer that aspect to you. However, we need me so he can talk to you.
Well, we can't put it.
Very impressed, number one, with the facilities as explained by the Minister of Health. I think there's a comprehensive attempt to make sure that each area is being served from the primary care level to the secondary hospital level. The minister shared with us the plans for the areas that don't have hospitals and the upcoming new hospitals in those areas. I've been impressed with the facilities and the doctors' abilities to maximize their resources and utilize their resources to the patient's benefit, which is something that we find that we have to do in America also. So that I'm sure, as the minister states, they would like for things to be better. We see the opportunity to help that process, and we're going to do everything that we can do. We return, we will get research and sources to finance. In the health arena, we know that international programs, various funding sources, grants, governmental, private, that have to do with the healthcare and particularly healthcare in developing countries. So we're going to launch a search for all of the contacts and resources that we have. Because we feel that we have, we know what the concrete needs are. So it's not that we're just going to say we want to help. Calabar needs help. Calabar has 2 hospital projects in progress that we know exactly what they need and how can we go about helping them to facilitate that.
Tomorrow morning.
I just said, I want to go to the south side. And this will come under the medical consulting division, the universal medical consultant. I would think, firstly, again, with more definition of what the physicians need here, what the hospital services need, what specialty training for, and probably more so special technical training, be it surgical procedure or use of, say, a high-tech piece of equipment that is not currently in Calabar, that the hospital would feel would be beneficial to its patients, but they would need to have that doctor trained in the use of that equipment. I would think those would be the most priority concerns as far as physician exchange for physician training to facilitate that aspect of it first, primarily. And again, we have contacts and connections with the graduates from major medical institutions across the United States. Of course, we have 3 black medical schools in the United States, which are closely affiliated with our national and state Black Doctors Associations and National Medical Association, which is the national organization of black physicians in the United States. And through that organization, as well as our other medical school connections, we feel, that type of facilitation would not be hard at all. And so I see that initially with physicians or residents in training that want to bring back new techniques, new knowledge, to the community. As far as medical students, I think that that would be something that we'll be looking into as far as I know that there are exchange programs and funding for those types of things. We're going to be looking into those things secondarily, because I think it would be an excellent opportunity for students. The other thing that we talked about was also from the knowledge that we've gained and the insight in just a short time, that it would be a fantastic opportunity for American residents in training to come and spend time here practicing in an environment that where you can't depend on tests and machines as much as we do there. It forces the physician to be much more clinically adept. They have to depend on their eyes, ears, nose,
now,
everything that they have.
Yeah, okay. Now, if I may ask, considering the fact that it's a third world country, and the level of equipment here, and not when you want to talk in terms of comparison, what is happening in the United States and other developed countries. Now, would you think that idea of bringing in physicians in training to come and do their practice here best suited for our health program?
Bringing in physicians from America.
Who are now in training to come and practice here.
Well, when I say in training, I was thinking in terms of probably senior residents. So these are the senior residents who are just about ready to go out into practice and receive their final specialty training degrees or certificates. I think it would give them a perspective. I think they could do a lot here. They bring a high level of expertise. They're fully utilized in the training institutions and the communities in America.
You might want to give them an idea of how our training differs. That's someone who's been training for 12 years by the time they're ready for
4 years of medical school.
well, 4 years of college.
4 years of college and 4 years of medical school. And then we'll say family practice, which is primary care specialty. That's a 3-year residency program, okay, after medical school. Surgery is anywhere from 5 to 7 years after medical school, okay? So we're talking about, in fact, Dr. Dalton worked in my clinic as a senior resident in ear, nose, and throat surgery. He was a resident, worked in my primary care clinic part-time. But during the week or the month, when I had patients with ear, nose, and throat problems, I would schedule him to come back when Dr. Dalton was on duty and to take full use of his expertise. So that I think that those types of students, residents, okay, senior residents in training, would be an adjunct to the hospital staff.
Now, if I may ask, on funding of this equipment, do you have any other company that you are working in collaboration in terms of funding, or is just your company on its own that's doing the funding?
At this time, the company is not engaged in any funding at this time, but the resources that we have with other companies, and this is going to be the first thing that we do when we return, is delineate a proposal based on our discussions with the Minister of Health, a proposal of the equipment that will be needed for the 2 new hospitals, and then seek funding sources that will help finance that and engage, bring them together with the Ministry of Health to discuss financing. We feel that we have several sources that we can approach, and again, that's primary on our list when we return.
If I may ask, I would want to find out these sources. How valuable are these sources?
very viable funding sources. What we have to determine is, and also structure the proposal, possibly to make sure that it conforms to some of their funding guidelines. We're going to prepare a generic proposal, but we may have to reshape it depending on, they say, well, you know, the way that's set up, we cannot fund it. But if it, you know, has a curve here and a hook there, that we can, that falls within our purview. But these are again, these are governmental programs. Mr. Olisa is going to be checking with governmental sources that we have been made aware of through our contacts at medical schools. In preparation for this trip, we met with university officials who had just made a tour of Africa, and they had leads for governmental and international funding sources that dealt primarily with healthcare development in third world countries. So the specifics on that, we know where that information is. We have consultants that we're associated with that really know funding and financing, that can make sure that we have a proposal that will meet the specifications. Right? And so I just feel if I just would be very, I just have every reason to believe that we are going to be able to turn up some funding, financing, and if we don't, it'll be because none exists.
Okay. Thank you very much.
Okay.
I think
Just one question. We have had this problem and equipment, things like that. So considering the fact that you are going to enter into agreement with government, supposedly, to bring equipment, send equipment here. In other words, you are importing equipment. Now, how do you ensure standard of such things? You know, by the time it moves from there to here, how do you ensure that it's the right thing at this time? Exactly. Considering the fact that this thing has to do with health.
Exactly. We would have to, in fact, we talked with the minister as far as what warehouse capabilities were here, distribution from Calabar to the hospitals outlying, as well as soft supplies to the hospitals in the state system. That would require some personnel here who will be knowledgeable of the equipment. The other thing is that in order to bring equipment in, we have to have technical support. So the technicians, we spoke with, in fact, whether or not the equipment ever, whether or not that happens or happens sometime in the future, the discussion of medical technician training is something that is that can be put into place immediately to save the system money. The minister mentioned equipment that breaks down in the hospitals that has to be thrown away because it cannot be repaired. That can be stopped immediately with a small investment in training medical technicians. You have equipment now from Europe. The technician needs to be well versed in that equipment, and then any equipment coming in from America, Mr. Olisa has arranged through his manufacturing contacts that they would be willing to train technicians. And once the technicians have mastered medical technical equipment, be it European and American specifications. Again, Mr. Olisa has discussed the voltage differences. All of these things will be arranged with the manufacturers prior to shipment to make sure that the equipment comes in ready to operate.
I think as a supplement, the answer Dr. Hall has just given to you. The team of the physicians that will be acting as a consultant to the company and myself, we are constantly, updating our inventory in the area of new technologies, and new development in some aspect of those. As far as sending anything that is outdated or that may be defective in any way, that's one thing that we will try to see that doesn't happen. The same standard of service that we render to American hospitals will be done to African countries. That's one of our philosophy that Bezel Medical adopted when it came into existence, to make sure that African countries get the same level of service that has been rendered to American hospitals as well.
I did inquire from the minister as to what research was going on here, if any, and I don't think there is any at all. But there should be some, and we need to look into as a future consideration, some quality control lab that may be able to random sample drug shipments and things of that nature to make sure that what's supposed to be in the pill is in the pill. And that's something that I am a pharmacist prior to going to medical school, and that is a very important consideration. In fact, even in America, there have been bogus generic drugs put on the market from not containing the active ingredient, and then even if if a pill has the active ingredient in it, if it does not release it in the body, if the active ingredient stays in the tablet and goes down the toilet, it still doesn't do the patient any good. So that there have been tests and procedures to assure that that type of thing doesn't happen. And that is something else that would definitely, and that may not be something that has to be in the state. That's something that I would think that the federal government, to protect the country, could employ something like that, quality control standards and evaluation.
With the commencement of the airport procedure, as a cost-saving measure, would you consider setting up your company right here, manufacture these goods to service the West African countries? I mean,
that would definitely be a long-term goal. It's been talked about that a successful participation and relationship with Calabar would certainly lead to more expanded business on the continent, and that would be it would necessitate at least initially warehousing and distribution here, and then of course getting into manufacturing as much as possible. And with the rubber industry, I know that the first thing that came to my mind was processing latex, which is a shortage of basically around the world with the AIDS and the increased, universal precautions necessitating rubber gloves from morticians, emergency crews, police that handle any bloody victim or that type of thing. That latex gloves and condoms are needed around the world, and even in America, that we run into shortages at times.
yeah.
And that is something that immediately came to my mind, the possibility of what that would entail, setting up a latex processing plant that could make greater use of the rubber being produced. that the raw material is here.
Okay. Thanks so much. We wait for the bilateral agreement that we sign between you and the government.
Do you need to ask him? He's in different area.
I mean, he
and David Ebri, the Secretary of State Government, the Honorable Commissioner for Ministry of Health, and other commissioners here present, members of the, or rather, visiting representatives of Bethel Medical Training Center of the United States, chief executives of boards and Park State Health, directors general, and directors. Tonight's event, combined performance, is held at the instance of the Ministry of Health for our visiting guests from the United States of America, of Bethel Medical Training Center in the United States of America. We are here to strictly entertain them tonight. We will go through the gamut of the African experience in order to introduce, you know they are well introduced to the African culture, but we shall also introduce the African American representatives here present to most of the African experiences that we have. We are going to start tonight with the choral renditions that will express a bit of what we have during the Moonlight Night experiences and also go through the traditional dance experiences too. We hope that this will create some nostalgia in you, for me. And without much ado, we'll go straight into the program and introduce to you some choral renditions that are traditional to Perseverance, choral music.
Mama,
on the moonlight night, underneath the tree at the village square. That was the choral group. Before we go into the next entertainment, I'd like to introduce my co-conference of the night, and he is the head of performing arts, and no other person than Mr. Sylvester Odie. We will be working together tonight to effect perfection on stage.
Excuse me, my lady, tell me what's your name. I go crazy when I see you walking down the street. But you call me Casanova, but it is not true. 'Cause my baby, I'm crazy over you. I'm not Casanova, I'm not Romeo. I don't smoke marijuana. Girl, you must know, the only thing I'm guilty is my loving you. Be my baby, I'm crazy over you. Call me Daddy Wilson, Daddy Wilson, Daddy Wilson. I'm gonna do you ragamuffin, ragamuffin. If you wanna be happy, don't forget my name. Just call me Daddy Wilson. Daddy Wilson, Daddy Wilson. I'm gonna do you ragamuffin, ragamuffin. Anytime you want me, don't forget my name. I beg your pardon. Are you Mr. Ragamuffin? Yeah, yeah, yeah. Call me Daddy Wilson, Mr. Ragamuffin. Call me Daddy Wilson, Mr. Ragamuffin. Call me Mr. Ragamuffin. Call me Daddy Wilson, Mr. Ragamuffin. Yeah, call me everything you know, woman and money, and you get up and read the money and tell pleasure. When me double big girl with a big big salon, so me can't take the home when you have ambition. Uptown call me, downtown call me, everybody call me Ragamuffin. White man call me, black man call me Ragamuffin, Ragamuffin, fire! Sing poetry and it's good for you. Money and God with me. All I need is a guy like you to standing on. Can't you see I'm thinking that I'm crazy? Everyone can see. I'm a baby, I'm so in love with you. I'm not Casanova, I'm not Romeo. I don't smoke marijuana. I love you so. The only thing I'm crazy is my loving you. Be my baby, I'm so in love with you. Call me Daddy Wilson, Daddy Wilson, Daddy Wilson, and I'll pay you ragamuffin, ragamuffin. If you wanna be happy, don't forget my name. Just call me Daddy Wilson, Daddy Wilson, Daddy Wilson. I'm gonna do you ragamuffin, ragamuffin. Anytime you want me, don't forget my name. Everybody call me Daddy Wilson, Daddy Wilson, Daddy Wilson. I'm gonna do the ragamuffin. Anytime you want me, just call out my name. Whoa, Daddy Wilson, Daddy Wilson. Ragamuffin. If you wanna be happy, don't forget my name. Daddy Wilson, is that a movie style? Call me Daddy Wilson, Mr. Ragamuffin. Call me Daddy Wilson, Mr. Ragamuffin. Give me